Hi, this is Gene Ransom with MedChi, the Maryland State Medical Society. I'm the CEO here, and I'm joined today with Dana Lubrani Kaufman, who is one of our lawyers, who is a very seasoned lobbyist in Annapolis and has done all kinds of incredible things in her career, including working in the governor's legislative office, being staffed to a committee in the House of Delegates, and for the last 15 or 20 years, she's been a lawyer lobbyist, and most recently a partner with the firm of Schwartz, Metz, Wise, and Kaufman. So, Dana, thanks for being here with us today.
No, thank you, Jean. I appreciate the opportunity to be here and to also talk with you today about Maryland's new prior authorization laws.
So, and that's what we want to focus on. MedChi had an incredible session this year, got all kinds of things done. But one of the things that I know you've been working on for the last couple of years has been prior auths. So maybe you can tell us a little bit about the landscape of what's going on or what happened during the 2024 session on prior authorization and utilization review.
Sure. So Maryland basically during the last 2024 legislative session passed Senate Bill 791 and House Bill 932, which really ends up being one of the most comprehensive laws in the state. In the country for protections around carriers' utilization review policies and prior authorization. So in a little bit, we'll go through that bill. But what also was very important is that afterwards, from the work that MedChi did on Senate Bill 791, the Maryland Insurance Administration released a bulletin that clarifies the current law around therapeutic exchanges, step therapy, and prior authorization. And some of those changes are really astronomical for the concerns that we heard from physicians, especially when it deals with the reauthorization of medications that patients currently are on and then have to be reauthorized and too often get a denial. So we'll talk about that in a little bit as well.
So Dan, I know I'm a lawyer, but you've forgotten more about this issue than I've ever known. And I got to say, I know you're an expert, but I think one of the things I do know with my basic understanding is the first thing we really need to ask is what will this law actually cover? And that can get very complex. So can we talk a little bit about that?
Yes, and that is a great question, and it is one that I know does frustrate the physician community. So unfortunately, Maryland's law only covers what is known as the fully insured marketplace, which is about 18% of the market. It does not cover Medicare, Medicaid, or ERISA plans, which is typically your large employers. So the fully insured marketplace is really those individual and small group plans. So again, like I said, it's 18% of the marketplace. A couple years ago, the Maryland Insurance Administration put in legislation, which was passed by the Maryland General Assembly, which makes it much easier to determine if your patient is covered by Maryland's law. Basically, if you flip over the patient's insurance card, if it is covered by the fully insured marketplace, which also means that it's covered, that Maryland laws cover him, you will see the notation either MIA or Maryland Insurance Administration. If it says either of those phrases, then yes, you are covered by the 18% market, and the Maryland laws cover you, and you have the protections that we fight so hard to get into Maryland's law. I will point out that if it does say the Maryland Department of Health or MDH, that is Medicaid. And while these provisions that we're going to talk about aren't covered, Maryland Medicaid does have its own set of rules. So if you do have issues, we still want to hear from you on those. So just be mindful of that. But really what you're looking for is MIA or Maryland Insurance Administration.
Right. And one of the things I want to point out, and I think you did with the Medicaid piece, that obviously we've been working for some protections there. The other thing I would like to point out is that a lot of the third party plans that manage the ERISA plans will create rules that work for both the Maryland and the ERISA plans. So you might get some benefit on the ERISA plans where they just comply with the rules because it's easier for them from an administration point of view, even if they're not required. And the third thing I want to point out is that MedChi is working very hard with the AMA and other national organizations to try to do reforms around Medicare and Medicare Advantage with regards to prior auth, as well as the ERISA plans in Washington. So I wouldn't want people to get dejected when they hear, oh, it's just covering a percentage of the market or whatever, when the reality of it is that when something like this gets passed, a lot of times the insurers end up applying it across the board. And secondarily, we're continuing to work hard to see if we can't do something on the federal level with our partners, the AMA. So Dana, maybe you can just do a deep dive into what you actually passed in Maryland and what you guys got done, because it really is impressive.
Thank you, Jean. Sure. And so just to note that anytime there is a change in insurance law, most likely that change is effective January 1st, 2025, or the following year of the General Assembly. And as we get closer, MedChi will be releasing some additional information to help our physician members be able to identify these issues quickly. So you will also be able to identify when the insurance carriers are not complying, which we're also going to talk about. So really what this law does is, if you put it in buckets, what we were trying to do is reduce and streamline the volume of prior authorization requirements, increase transparency and communication from the insurers to the physicians and patient, enhance the peer-to-peer review process, and really look at the timeframes from when a decision has to be made by an insurer and what happens if that decision timeframe is not met. So we can go through each one of these. So as far as reducing and streamlining the volume, the biggest issue that we had in the bill was what we called the reauthorization piece, which was basically if you've had a patient who has been on a medication and is being treated effectively for that, we wanted to make sure that the patient could stay on it. That larger provision was removed from the bill, but I am going to talk about the MIA Bulletin later, which actually reaffirms much of that provision. But the bill itself, the two areas that stayed statutorily was the reauthorization when treating a mental health disorder, or when the drug is an immune globulin. I always mess up with this word, globulin. If those two exist, then, and your patient has been effectively treated with that medication, then the insurer can't deny the continued use of it. The other prohibition that passed was you no longer can be denied for dosage changes unless it is an opioid. So we know that was two big issues that we were seeing as far as the level of denials. A couple things that we also did was we made sure that if a patient was changing carriers, that they could stay, that their prior authorization would continue for 90 days or the course of the treatment when they changed carriers, which would give the new carrier the ability to perform its own review. If the carrier or any carrier is going to implement a new prior authorization, it requires now 60 days notice as opposed to 30 days notice. And similar to the final Medicare Advantage rule, we have the same language now in Maryland's law that requires a carrier to approve a course of treatment of a non-medication health service for as long as medically reasonable or necessary to avoid disruptions in care, which again is very similar or exactly like the rule for the Medicare Advantage as well as DC.
All right. Well, Dana, go ahead through the communication and transparency rules for us.
Okay, so another thing that we did is if you believe that you need an expedited review, which is a decision within 24 hours, that is now determined by the physician, not the carrier. And in the law, there are specific reasons for asking an expedited review, which for the most part is that harm will occur to your patient. We've heard a lot about standards not being followed and standards of care basically by the insurance companies. So instead of having what we call homegrown standards developed by the insurance carriers, we now are requiring that the standards must be developed by nonprofit medical or clinical specialty societies or organizations. There is also other provisions that have to be followed for the adoption of standards by the insurance companies, but they are too numerous to put on one slide. As far as denials, right now you do have to get within 5 days of getting a denial, you have to get it in writing. But they're pretty broad. So there's language that has been put in that requires that the insurance companies have to point to the specific criteria and how the physician's request failed to meet that criteria. If additional information is needed to make a determination, then within a specific amount of time, the insurance carrier must ask for that information, but it has to be with specificity, and it also has to be supported by the standard used in making the decision, which has to be communicated to the physician. The last thing we did is that if there is a denial, there has to be a dedicated call line or a dedicated and monitored email for the physicians to be able to call the insurance carriers rather than just forcing you to go through the general customer call line.
I think it's really good that the focus was putting it back in the hands of the physicians, because I hear lots of complaints from physicians who say that it's just not a physician-centric process. So to that end, can you talk a little bit about the peer-to-peer reviews and some of the required timeframes in the legislation you got passed?
Sure. So first of all, the way the law is now, a peer-to-peer is discretionary. It's not mandatory.
Mhm.
So if a physician requests a discussion with the insurance carrier on their decision-making process, then the insurance carrier must provide that, and it has to be done within 24 hours. I think the biggest change, though, is that it has to be done by the licensed physician who made the initial denial, and that physician has to be board certified or eligible in the same specialty and knowledgeable about the requested healthcare service or treatment through clinical experience. I think that is the biggest change when it comes to peer-to-peers, because oftentimes the physician were talking to a pharmacy tech or someone along those lines, or somebody who wasn't even in your specialty. So that is a major change. And then another major change is if the carrier fails to meet the required timeframes in the law, the request will be deemed approved.
And that's a huge change from prior years, right?
Correct.
Yeah, talk a little more about timeframes. I know you
Yeah,
mentioned it,
so
but
the time frames can get a little bit confusing. So emergency requests, the decision has to be made in 24 hours. Any initial determinations that are non-emergency for both prescription and healthcare services that are not done electronically. So prescriptions, we do have an electronic process, but for healthcare services, and non-electronic prescriptions, it's 2 working days. If you are requesting an extended stay in a healthcare facility, it is 1 working day. Now, if you use the electronic system, which we highly encourage everyone to be using the electronic system for either step therapy or pharmaceutical requests, it must be done in real time if no additional information is needed, and 1 working day after receipt of any requested information. And then let's not forget that as far as that requested information, you have to kind of go back to one of the previous slides regarding the fact now that it has to be supported by the standard of care used, which has to be communicated, and they have to be very specific on what additional information is requested. There is also language in the statute about making sure that it already has not been submitted, because we've heard a lot of complaints that we've sent all the information, they're just not reading it. So there is some language built in there as well.
so that, and obviously under Maryland law, the standard is we should be using electronic submissions. There are exceptions, but most of this stuff should be done electronically. So these timeframes are significantly better than what physicians were experiencing prior to this law.
Correct.
Right. And so that is a nice summary of the bill. Can we talk a little bit about the MIA Bulletin, which I think is one of those things that you guys got done under the radar and after session that's might even be as big a win as the statute. So maybe you can talk a little bit about that.
I definitely think that is the case, Gene. So the MIA on May 24th, 2024 issued a bulletin, which is basically clarifying their interpretation of Maryland's current law. So everything I've talked about up to this point goes into effect January 1st, 2025. But this bulletin and the provisions that are addressed in this bulletin are effective right now. And to Gene's point, one of the issues and the reason this bulletin was issued was we kept asking during this process, especially when it was talking about the reauthorization, is if the definition of step therapy is anytime you require a patient to change a drug, how are we seeing patients being kicked off drugs that they have been on for 5 years when step therapy basically says that they can stay on it if they've already been on it for 180 days. And we could not get a good answer from the carriers. So basically the MIA, after we were talking to them about it, issued this bulletin, and the bulletin addresses 3 points: therapeutic interchanges, step therapy, and prior authorization. For the therapeutic interchanges, and you will see at the bottom of this slide, there is a link to that bulletin, which we highly suggest every physician and their staff read it. But a couple key points. So for therapeutic interchanges, you have to remember that the prescriber must agree to any change, and the interchange must be disclosed to the patient. So again, it is in the hands of the physician or the prescriber whether or not to agree to a therapeutic interchange. As far as step therapy, again, this is one that in 2023, we changed the definition. And I will admit that when we did that, we probably didn't completely understand the ramifications. But when we changed the definition, we changed it to basically say anytime that you require a patient to change medication, then it falls under the protections of step therapy. So the MIA bulletin clarifies that a patient cannot be denied continued use of a drug, and continued use would be if they've already been on it for 180 days, if the patient has been effectively treated with the drug, and the prescriber believes that the patient continues to need it. So even if there are 5 other alternatives that may be less costly than the drug that the patient is on, the patient cannot be denied being kept on that drug. Now, I will point out that this doesn't stop the insurers from either moving it to a different tier or eliminating it from the formulary altogether. But if that occurs, there is another law on the books that has protections as well for those 2 situations. Lastly, the prior authorization. Again, it doesn't matter what it's called. If the patient has already been on a drug, it goes to the step therapy. And if they haven't, and you're requiring them to take a lower cost alternative, it must be based on the criteria and the standards. And if it's denied, then it becomes an adverse decision and the appeal rights go into effect. So this is a very, very big bulletin that really changes, I think, the landscape, especially when it goes to so many drugs being put on the preferred drug list and changed on an annual and sometimes quarterly basis.
All right, this is pretty huge. This is a big change. And the important thing about the bulletin is that's in effect right now today. That took effect immediately, correct?
Correct. So right now it is in effect. So anybody who has a patient that is under the fully insured marketplace and is going for a reauthorization of their current medication and is told that they must try these 4 alternatives, needs to take a look at this bulletin or give us a call, because that is they cannot be denied.
All right. So let's say that we have a physician, who's watching this video and they go, wait a second, I've got someone where they violated the bulletin or it's after January 1 and the other law is taken effect that we described and there's a problem there. What do you do? What happens? What happens if there's a violation?
So compliance is key here, and we understand that our physicians, you all are so busy taking care of your patients, but at the end of the day, we can only do so much unless we know that there are violations. So if you do believe that a carrier has violated the law, and we are going to be, as MedChi, watching this very closely, we are asking you to please file a complaint with the Maryland Insurance Administration. Each year, the Maryland Insurance Administration puts out what's called the Appeals and Grievance Report. And when a dispute is filed with the Maryland Insurance Administration, over 70% of the time, the carrier's decision is reversed in favor of the patient, which means 7 out of 10 times that decision was inappropriate and the MIA reverses it. Now, the bigger issue too is that a complaint can trigger a market conduct survey, which is when the MIA goes in and does a larger audit, which can also then require the carrier to pay fines or put in remediation measures. At the bottom of this slide, there is the MIA complaint form that can be done by the physician or the patient. If you have any questions about this process or whether or not you do believe that a provision has been violated, please give MedChi a call if you need some assistance. There is also the ability to have the Health Education and Advocacy Unit of the Attorney General's office assist you as well. So we definitely are going to be paying very close attention to compliance and making sure that the carriers are implementing this bill as it is intended.
And we'll put the links to the complaint form, the bulletin, and the MedChi website in the video information below. So you can look down at the information below and you can click on any of the links. Dana, I cannot thank you enough for all your great work on this bill. I know this was a multi-year effort in the General Assembly. It took a lot of work. I did want to give a shout out to some of the legislators who helped us out on it. Did you want to mention some of the legislators who were key to getting the legislation passed?
Sure. So Delegate Ken Kerr, he introduced the bill in 2023, as well as Senator Kathy Klossmeyer. That version went to a summer work group. And during that work group, Delegate Bonnie Cullison, as well as Senator Kathy Klossmeyer, participated in that under the direction of Chair Jocelyn Penamelnick and Chair Pam Beidel. So between the 5 of them, we had some really strong advocates pushing for change. And I do think that we had some great momentum with both the committees as far as HGO and Senate Finance. So, but Delegate Ken Kerr, Delegate Cullison, Senator Kathy Klossmeyer, and Penamelnick, and Senator Pam Beidel, kudos. They were great advocates for us.
Yeah, what's the saying? Victory has 1,000 mothers.
Yes.
Anyway, but
And I was
no,
very happy to share in that.
yeah. So anyway, well, I can't say enough about how wonderful a job Schwartz Butson Wise, the premier Annapolis lawyer slash lobbying firm, has done for MedChi. Your firm has been the MedChi lobbying firm since I believe 1996. So for almost 30 years, you're getting close. You're only a couple years away, and in the long list of successes, this has got to be one of the top 5 in my mind. This is major legislation, major change. And hopefully some of the national folks can look at what we've done and see if we can't get some changes for these ERISA plans and these Medicare Advantage plans in DC so we can have a fair set of rules for everybody. So thank you so much, Dana, for the time to talk to us today. Again, if you have any questions, you can always reach out to MedChi. We would love to hear from you. And you can email us at generansom@medchi.org, or you can email Dana dkaufman@sportsmetswise.com. Thank you.
Thank you very much.